Hi,
Good
Dr.
evening,
Neha.
ma'am.
Hi. For me, it is morning.
Good
Morning.
morning, ma'am.
Good evening, Jyoti madam.
Good evening, good evening. Yeah.
Okay. Dr. Jichi, ma'am, we can start. Can we start?
Yes, please.
Okay,
We,
Dr. Nidhi, please.
we are already 3 minutes late.
Yes. Good evening, Dr. Ziba, Dr. Charanjeev.
Good evening.
Vindhya ma'am, you want to initiate?
No. Okay. Good evening, everyone. So today we have the first monthly webinar series, which we decided will be now held every month on the 7th for 70 minutes at 7 p.m. So without any further delay, now I hand it over to Dr. Nidhi, who is the Joint Secretary of ISCCP, to please initiate this meeting today. Over to you.
So good evening and welcome all in the first monthly webinar. My introduction has been, taken by Dr. Bindya itself. So I have no line to be left for me to introduce the webinar series. So as ma'am said that without wasting any further time, we will start our academic feast. So first I would like to invite our dynamic Dr. Aruna Nigam, President of ISCCP. Presently, she is Professor and Head of Department at Hamdard Institute of Medical Science and Research. Over to you, ma'am.
So, thank you. So, good evening, all my loving, all respected seniors, my colleagues, and my dear ISCCP members. I welcome you in this first monthly series of webinar that is 777, that is every 7th of the month, 7 p.m. and for 70 minutes. We are going to give the time for reproductive health, for cervical health, and we are going to work towards the cervical cancer elimination, which is our motto, to eliminate the cervical cancer by 2030. We are going to work on many other matters of the reproductive health, but that generally be related to our cervix and the vulva, which is the focus point of Indian Society of Colposcopy and Cervical Pathology. With the blessings of all my seniors, Dr. Swaraj Batra, Dr. Juchi ma'am, Dr. Sarita, Dr. Leela, and Dr. Gauri, and everyone, we will try to do the things which they have given us as a legacy. And we are going to take forward this ISCCP to new heights with the support of you all. This seminar every month for 70 minutes, we are going to have a one topic that is on a lecture format, and the other 30 minutes we are going to invest on either any recent study or on a case presentation so that we can have a practical sessions. As this is in a webinar mode, you have to write your questions in a chat box, which can be answered by our experts during the time, and later on also we can answer those questions in our WhatsApp group. Whatever problems you are facing in joining the WhatsApp group, or if you have not included, or if you are not receiving the messages, please do communicate to us, because we want to be in touch with you all. Together only we can work. We need your support to achieve our motto, and many new things we are going to add up, and previous things which have been started by all the past presidents we are going to continue. If you have any suggestions, we are there to see it and apply it to our curriculum. So it is very important that these suggestions should reach to us. So I would request, whatever suggestions in your mind, in your right mind, please send it to us on our personal WhatsApp messages, or on the website, on the email, which is very much there, secretariat@isccp.co.in. You see, you have to see all the mails, because from now onwards, we are going to send all the mails via ISCCP official mail also. WhatsApp is a very good way to communicate, but please go on seeing these mails also, which will give you more insight into, and you are not going to miss anything. And if any problem is there, We are there to help you out. You can reach out to any of the EC members which will be there. Website will be updated with the new members in next 15 days time, as we have taken over on 18th or 19th April, and lot of things which have been done by Dr. Leela and her team and previous teams. We are getting ourselves updated with that. So give us time for that, but within 15 days, everything will be updated on website also. And please do visit our journal website, which is very important. That is jcgltp.in. This is a Walter Clover's published journal. So I will request you to all go to our website. That link also I will post in the WhatsApp group. With this background, I would like Dr. Nidhi to now continue with the proceedings of the webinar today. Thank you.
Thank you, ma'am. So let's start with our first lecture. For the lecture, I would like to invite our chairperson. Our first chairperson is Dr. Vijay Jussi, the Teachers of Teacher. She
Nidhi,
is
Nidhi, don't waste time. Name
okay,
and
ma'am.
category.
Okay.
Let's have more
As
discussion
you
for
say,
academics.
ma'am is senior consultant at Metro Cancer Hospital and past professor at Safdarjung Hospital. She is a special interest in gynae oncology. Our next chairperson is Dr. Leela Digumarti. Ma'am is the past president of ISCCP. Third chairperson is Dr. Ziba S. Zirhazpuri. Ma'am is the cornerstone of pathology department at Hamdard Institute of Medical Sciences. Welcome our chairpersons.
Thank you.
And now our speaker, Dr. Charanjit Aluwalia. Ma'am is professor and unit head in the Safdarjung Hospital. She has a special interest in gynae oncology. Ma'am is going to tell, or I would say, unravel the enzema about the molecular markers in cervical cancer screening. Over to you, ma'am.
Thank you. I thank all the organizers for giving me the opportunity to speak today. And I will just share my screen. I'll just share the screen again. I think I was not.
Ma'am, we
I
could
would
see your
your screen.
presentation also. We could see.
Yeah, we could see.
You are muted, ma'am. Yes, ma'am, it's visible.
Yes, it's visible, ma'am.
Charanjit, you are muted. Unmute, unmute.
Somebody needs to tell her she's muted.
No, I told her.
Ma'am, you are muted. Kindly unmute yourself. Charanjit, ma'am.
Message her, I guess, maybe.
वो बोल रही है उसको not able to probably see.
Nidhi, maybe you can give her a call or.
Yeah,
I'm calling her.
I have unmuted. There is something I'll do it once more.
Now you're audible, ma'am.
Yeah. But I'm unable to share it.
But you'll be seeing your presentation on screen.
You are seeing my presentation?
Yeah, we
Yeah.
saw it.
We saw it, now it's gone again. You share it again.
Okay, I'll just do it. I'll just share it again. Actually, share option is not coming. Okay, now it's there. Okay.
Yeah, it's visible, ma'am.
Yeah, it's visible, ma'am.
And am I audible?
Yes.
Yeah, you're
perfect.
audible too.
Okay. Thank you. Okay, so I'll be talking about molecular markers in cervical cancer screening. So I'll be talking just about molecular markers. So we already know that cervical cancer is the second leading cause of deaths among women in India. And in 2025, by the end, the cervical cancer burden is going to increase to more than 2 lakh cases. So now early detection is the key. And we should have a robust screening which ensures early detection, because studies have shown that if a woman is screened for cervical cancer only once in her lifetime, her risk of cancer can be reduced by 25 to 30%, because cervical cancer is largely preventable and curable. So as long as it is detected early and managed efficiently, we can prevent all the mortality and morbidity. Now again, we know the role of human papilloma virus. About cervical cancer pathology is dominated by human papilloma virus infection, and more than 99% of cervical cancers are caused by human papilloma virus. And it is the high risk genotypes. There are 13 genotypes of high risk virus which are considered carcinogenic, out of which 16 is the 16 and 18 are most prevalent types. The 16th is the most prevalent genotype. Okay, so 16 is the most prevalent genotype in both squamous and adenocarcinomas, and 18, the second most common, is found in higher proportion of adenos as compared to squamous. Now, if we look at HPV infection, there is a very high prevalence of HPV infection in the age group of 20 to 24 years. But this infection is transient, and 70% is cleared within 1 year, and 90% or more than 90% within 2 years. So it is the transient infection is not responsible for causing any disease. If the infection persists, it is the persistent infection which leads to CIN and then progresses to cancer. So now human papilloma virus causes transient infection which can lead to CIN1 or CIN2, but since the infection is transient, most of CIN1 and CIN2 they regress, and only 1 or 1.5% will progress to cancer. For CIN3 lesions, the regression rate is 32%. So now, what does this persistent infection do? So if we look at this figure here, this is the human papilloma virus DNA. It's a DNA virus, how the papilloma virus looks like. And this virus has a number of viral genes. So now that I'm talking about molecular markers, we have to know about the structure of the virus and the various viral genes. So the virus has a gene L1, L2, which encodes for the cover of the virus. And then the virus has a few genes labeled as E1, E2, E4, E5, E6, and E7. Out of these E genes, it is E6 and E7 genes of the virus which are responsible for causing cancer. And very important, now whenever a female gets HPV infection, the virus enters the cervical epithelial cells, and the viral DNA enters and it sits in the cytoplasm of the cell in an episomal form here, golden colored circular episomal form. Now this is transient infection. The viral DNA is sitting in the cytoplasm. This is transient infection, and this can be cleared. However, in cases where the infection is there for a long time and it is due to high risk HPV viruses, in this case, this yellow colored episomal DNA, now it will go inside the nucleus, and this viral DNA will get integrated into the human DNA. And human DNA, once the human DNA starts to transcribe, there is something called as transcription and translation, and then proteins are produced. So when the human DNA in which the viral DNA has got integrated, once it starts transcribing, viral E6, E7 proteins are produced, which are responsible for cancer. So virus E6, E7 messenger RNA is produced, and then viral E6, E7 proteins are produced inside this cell, which will make the cell go towards cervical cancer. So how E6 and E7 make the cell go towards cervical cancer? Virus E6 will damage P53. P53 is a very important tumor suppressor gene. If E6 of the virus damages or dysregulates P53, cell will walk towards cancer. Then E7 protein of the virus, E7 will combine, will attach and dysregulate another important tumor suppressor gene called RB. If RB is dysregulated, again cancer will be produced. Now, when E7 dysregulates RB becomes dysregulated, and at the same time, when RB is dysregulated, transcription factors called E2F are released. They are transcription factors, and these E2F transcription factors now make the cells multiply a lot. So loss of P53 because of E6 and loss of RB because of E7 and release of these transcription factors now will make the cells go on multiplying and produce a cancer. Also, another thing that we have heard, we already know, is when E2F levels in the cells increase, they also lead to increase in P16. So we use P16 as a surrogate marker for HPV infection, because when all this circus happens in the cells, P16 levels will increase. So thus the cells that are walking towards on the path of cancer, they will have increased P16 in their cytoplasm. So now coming to, with this background, coming to screening, traditionally VIA, Willi, and Pap smear, they have been recommended for screening of cervical cancer. Now, newer methods, liquid-based cytology, of course, it's not very new, and HPV testing. So HPV testing has been recommended. Now, if we compare HPV testing with our Pap smear, we have conventional Pap smear and liquid-based cytology. Both conventional Pap smear and liquid-based cytology, they have very high specificity, but they have low to moderate sensitivity. In case of Pap smear, it is 37, conventional Pap 37 to 84%, whereas liquid-based cytology offers some advantages, that is improved fixation. For a pathologist, the obscuring factors are reduced, standardized cell transfer, screening time is reduced, better sensitivity and specificity. And also, the material in the liquid-based bottle, cytology bottle, can be used for DNA sensitive testing. However, what are the limitations of cytology alone? Cytology has low sensitivity as compared to HPV DNA testing methods for CIN2. Then in cytology, high false positive rates, false negative rates due to lack of exfoliation of dysplastic cells. So especially in glandular lesions, sometimes the lesions may not exfoliate any cells. So you may write the report on Pap smear as negative, but actually the patient is having the lesion. Third, inaccuracy due to high variability between cytopathologists and between laboratories. I may not agree with my counterpart. She may say this is an atypical glandular lesion. I may say no, they look like normal endocervical cells. So this is inter-observer variability, and that is responsible for inaccuracies. And another thing about Pap smears and LBCs, they identify women with cancer precursors, but not women who are at risk of developing the cancer. Therefore, now comes WHO recommends do HPV DNA testing. Why? Because HPV DNA testing detects high strains of high risk strains of HPV virus. It is more objective test, and it is more supposedly more cost effective. So we will see why. And then as WHO recommends, start screening at the age of 30, and you can screen every 5 to 10 years. And for women with HIV, you start screening at 25, screen every 3 to 5 years. So as we saw, HPV DNA is more objective test, no inter-observer interpretation errors, high sensitivity, high negative predictive value. That is, if we say that HPV DNA test is negative, that means this woman is highly unlikely to have any lesion, and it offers a longer protection up to 5 years. But limitation, lower specificity as compared to PAP, because it detects both transient and persistent infections. So now there are 5 FDA approved methods: hybrid capture 2, Cervista, Cobas, Eptima, and BD Oncolarity, they have been approved by FDA for HPV testing. Now, utility of HPV testing, first point we already know, WHO says use it as primary screening, as a primary screening tool. Second, you can use it for co-testing also. Third, you can use it for reflex testing. That is, if we get an abnormal pap, ascus or agus cytology on pap, this can be followed by HPV DNA testing, and then unnecessary colposcopies can be avoided. Then another use is after CIN or adenocarcinoma in situ treatment, you can do an HPV DNA test and look for recurrent or residual disease 6 to 12 months after treatment. And this reduces the number of women who require frequent and long-term follow-up. And in low resource setting, WHO recommends that do an HPV testing. If HPV testing is positive, treat these women also. So thus, why do we say, why does WHO, why do we say this is cost effective? Because it reduces cost by triaging patients with appropriate management strategies, reduces unnecessary colposcopies and less frequent screening in low risk patient, and thus helps to becomes more cost effective. So now, as there are 5 FDA approved methods, the oldest one was hybrid capture. Now, all these methods except for Aptima here are DNA based method. That is, DNA based method means they look for human papilloma virus DNA which is integrated in the human DNA. So they look for the viral DNA. Now, hybrid capture 2 and Cervista, they detect 13 hybrid capture 2 detects 13 high risk HPV genotypes, and Cervista detects 14 high risk HPV genotypes, and both of them have been recommended for reflex testing and co-testing, but rarely for screening. And both are they detect HPV DNA, and they are non-PCR based methods. Then we have Cobas and BD Oncolarity. Again, they are also DNA. They also look for HPV DNA. Both of these are PCR based methods, and advantage of Roche Cobas is that it does it looks for 14 high risk HPV types, and it does partial genotyping. That is, it separately detects HPV 16 and 18 also. And BD Oncolarity, again, it is a DNA based method, PCR based, and it looks again for 14 high risk HPV types and then does partial genotyping for 16, 18, and 45. So it is doing genotyping of one more, that is 45. Then another advantage of BD Oncolarity is, now in BD Oncolarity, we are looking for which part of the virus. We are looking for E6, E7 viral gene, which is actually one responsible for causing cancer. So this test becomes more specific as compared to the other DNA based test. Last test which has been approved by FDA is Aptima test. Now, Aptima is a messenger RNA based test. So now in Aptima test, what are we looking for? We are not looking for DNA. We are looking inside the cells. We are seeing if E6, E7 messenger RNA is present, because if messenger RNA is present, that means this woman is likely to develop progressive disease. And here again, it looks for, it sees it, we detect this mRNA, messenger RNA of 14 high risk HPV types, and again genotyping for 16, 18, and 45 is done. Now, Aptima, out of all these tests for HPV for primary screening, WHO is recommending Cobas and BD Oncolarity, whereas Aptima is not being recommended, and the other two, hybrid capture and Cervista, are not being recommended for primary screening. For primary screening, it is Cobas and BD Oncolarity, and Aptima is being recommended for triaging the patient. So if HPV DNA test comes positive, and this test can look for high risk HPV DNA and then triage the patients, because if mRNA E6, E7 mRNA is positive, these are the lesions, these are the people who will require more aggressive follow-up. So these are the 5 tests. Now, challenges with HPV DNA testing: false positives and false negatives. So false positive, this is a HPV DNA testing is a very sensitive test, and it will even detect transient infection. Then non-pathogenic strain, those low risk HPV or cross reactivity with other viruses can also produce a false positive test. And it is, since it is very sensitive test, it can detect very low levels of virus that may not be clinically significant. And sometimes, in regressive lesions, the virus may persist. Again, that will give a positive result. And false negatives, time of doing the test. So we know that the concept of window period. So again, here, a window period means a person becomes infected, and when will the test come positive? That is the window period. So if we do the test during the window period, the test may come negative. So window period, approximately, it is recommended wait for 4 weeks after exposure. So 4 weeks approximately, though the window period is variable, but it is recommended that a window period of 4 weeks should be taken. Then viral latency. If the virus is latent inside, the latent sitting viral DNA is latent, sitting quietly in the human DNA, the test may come negative. If the sample is not collected properly, or it is not handled properly, not stored properly, then the viral DNA may get degraded and our test can come negative. So these are false positive and negative. So I talked about the 5 tests, out of which 4 were DNA based tests, and 1 test, Aptima, was mRNA based test. So now looking at mRNA based tests, now mRNA, as I told you, HPV DNA tests, what do? They just detect the presence of the virus in the human cells. Whether this virus is going to cause disease, lesion or no, they will not tell that. So they just detect the presence of high risk HPV. E6ER mRNA based tests, they detect not only the presence of virus, and they also tell you that the virus is the virus is now transcribing, and thus persistent overexpression of E6, E7 mRNA in the cells is a strong indicator of active oncogenic transformation and a high risk of progression to cervical cancer. So thus mRNA based tests are better. And so here is a comparison between DNA and mRNA based tests. So DNA based tests, they detect the presence of virus, presence of high risk HPV virus. mRNA based tests look for E6, E7 oncogene mRNA. So they just identify, the DNA test will only identify the virus. E6, E7 test will identify active oncogenic activity. Sensitivity of DNA test is higher. E6, E7 mRNA test is slightly lower because they will only will be positive if there is activity. That is, if mRNA of the E6, E7 is present. Specificity of DNA tests is lower because they detect transient infection also, but E6, E7 mRNA tests, they do not detect transient infection, so their specificity becomes higher. So obviously false positives are more common, whereas in E6, E7 mRNA based tests, they are lower. Risk prediction can detect HPV if it can. Okay, so they will tell you whether it will cause disease or no. And E6, E7 mRNA based tests, they better predict progression to CIN. Examples we have given. This is a mistake. Aptima should not be here. Aptima is here in E6, E7. So Cobas, hybrid capture, Cervista, BD oncolarity are DNA based tests. Aptima, pre-tect HPV proofer, nuclesense, and quantivirus are E6, some examples of E6, E7 mRNA based tests. And HPV DNA test, especially Cobas and oncolarity, are recommended for primary screening, whereas E6, E7 based tests, they are recommended more for triaging and co-testing. So just little bit, I have already told you, mRNA based tests are Aptima, which is FDA approved, which looks for mRNA of E6, E7 of 14 high risk HPV types. Nuclesense EZQ, this is again E6, E7 mRNA of just 16, 18, 31, 33, and 45, and not all the high risk. Then pre-tect HPV proofer by Norchip, again E6, E7 mRNA of 16, 18, 31, 33, and 45, something similar to Nuclesense EZQ. And quantivirus HPV, again, it detects E6, E7 of these viruses. So all these mRNA based tests have higher specificity than the DNA tests. They are more suitable for triage, and in other than Aptima, the others require more validation is required. So Aptima is the only one that has been approved by FDA. Now, in the on the group, WhatsApp group of all the ISCCP members, there was a lot of talk about point of care HPV tests. So I thought I should talk a little bit about point of care tests. So what is point of care HPV testing? It is a rapid on-site detection of HPV infection without needing complex laboratory facilities. All the tests that I have talked about till now, they require a very big laboratory setup. The machines are very expensive. The kits are very expensive. We need very trained technicians to run the machines, and the doctors to interpret the result properly. So with point of care tests now, they are rapid on-site detection of HPV infection without needing complex laboratory facilities. Advantages are result comes within 2 hours, whereas the other 5 tests, the other tests that I have talked about, there also the result can come within same day, 6 to 7 hours, or some like Cobas gives results within 3 to 4 hours. But point of care tests will give result in less than 2 hours. They are easy to use, no specialized lab equipment required, and some of these systems may allow for, they are being validated for self sampling also. And portability, these tests can be used in clinics or in field settings, making them ideal for low resource settings. And cost effectiveness, they are affordable and they are easy to scale, improving screening access in low income countries. So a few point of care tests are Care HPV, Expert HPV, AMFIRE, ONC6 test, and then TrueNat, about which there was a lot of talk on the ISCCP group. So now Care HPV again looks for DNA. Okay, now all the point of care tests look for HPV DNA. Till date, we do not have a point of care test which looks for HPV mRNA. So mRNA based point of care tests are not yet available. So all these tests, whether it is Care, Expert, AMFIRE, HPV, they are looking for, the three are looking for HPV DNA. They all three of them look for all the 14 types of high risk HPV. Result comes within 2 hours or within 2 to 3 hours, and all of them are the Care HPV, it is portable, battery operated. AMFIRE is battery operated. ONC6 is portable again. Gene Expert is also fully automated. Now this requires a little bigger equipment. Now target population for all of them is different, and cost range, except for Expert HPV, rest all the cost range is around moderate, so they become affordable and easy to use. Now for low research setting, it is recommended that Care HPV and AMFIRE should be used. They are all both of them, they are well suited for rural areas or countries with limited healthcare infrastructure where there are no specialized lab. But if you want to do high volume screening, then Expert HPV, ideal in larger clinical setting or screening camps that aim to test large number of women in short amount of time. And then third test, the next test, the last test that I talked about, that is ONC6 test. Now this doesn't look for DNA, this looks for E6 oncoprotein, looks for protein. So E6 oncoprotein is useful for triaging women who have persistent HPV infections and allowing clinicians to focus on those at high risk for developing cancer. So these are now TrueNat. TrueNat is it is available in India, and TrueNat is again a chip-based real-time PCR for rapid molecular detection, which is being, again, it's a portable and battery operated test, and this detects high risk HPV types 16, 18, 31 and 35, but not the other high risk viral types. And it is semi quantitative result within 1 hour, enabling same day diagnosis and high sensitivity and specificity, at least for these 4 HPV viruses. And again, it is suitable for limited resource setting. You need minimal infrastructure, and minimal biosafety requirements are there. So this is about the HPV testing. Now coming just 2 or 3 more slides on emerging molecular markers, which are more for triage and risk categorization. So they are newer markers, they are newer molecular markers, but they have not yet been validated. So these are number one, methylation markers. Now DNA, first, what is we are talking about human DNA inside the cervical epithelial cells. So what is DNA methylation? DNA methylation is chemical modification of our DNA. So if methyl groups are added to the DNA, or if methyl groups are added to certain genes on the DNA, the gene will stop expressing itself. So DNA methylation means there is a gene on the DNA. If methyl group gets added to that gene, the gene will stop function, or the gene will not express itself. So DNA methylation is a chemical modification wherein you add methyl groups to the cytosine bases in the DNA, and DNA methylation regulates gene expression. So if a gene becomes methylated, the gene will stop expressing itself. Now, what is the role of methylation in HPV infection? When the viral DNA gets integrated into the human DNA, at that time both viral genes and host genes can become methylated, and high levels of methylation are found in persistent infections and in high grade lesions or cancer. So now use of quantitative methylation based assays. So what is the use of these methylation based tests? We can use this methylation based test for triaging women with, if a woman is HPV positive, and if methylation markers come positive, that means this woman is more likely to progress to a high grade lesion. So triage test in women with positive HPV test or with ASCUS cytology, and thus it identifies high risk of progression to cervical cancer. So there is a test by name QIA Sure, which detects hypermethylation of two human genes, FAM19A4 and microRNA 124.2, and then GenTech detects hypermethylation of six host genes. So QIA Sure is associated with short-term high risk of progression to cervical cancer, and this GenTech is looks for methylation of six genes, and the samples are same. The test can be done on cervical scrapes, on LBC samples, vaginal samples, which may be collected or collected by the gynecologist. Then another emerging molecular marker about which we should know little is microRNA. Now, microRNAs have not been validated as yet for clinical use, but knowing about them is important because they are the future. So, what is a microRNA? These are, we all have microRNAs in our cells. They are small non-coding RNAs, and they regulate the expression of genes. So if genes that cause cancer, if microRNAs, they regulate gene expression. So if microRNAs become dysregulated, cancer causing genes will also, or cancer causing or cancer preventing genes will also become dysregulated, and cancers can be produced. So microRNAs are small non-coding RNAs that regulate gene expression. They modulate HPV driven oncogenic pathways, and they can contribute to tumor progression, and they are promising non-invasive biomarkers. Specific microRNA signatures can distinguish normal from precancer from cancer. So the in a if my low levels of certain microRNAs are associated with poor outcomes, high levels of microRNA 21 and 205 are associated with disease progression. Then if a patient has cancer, microRNA 155 is associated with resistance to chemotherapy or radiotherapy. And testing is again done by molecular methods like real-time PCR and NGS, which can be done on cervical samples or on liquid biopsies. And last slide, liquid biopsy, we should all know liquid biopsy is the future. Liquid biopsy is minimally invasive diagnostic procedure which detects cancer related material, or which even detects HPV DNA, which is, it detects circulating tumor cells DNA, circulating tumor cells, tumor cell RNA, protein, exosomes, and HPV DNA can also be detected in the blood or in the body fluids like cervical secretions. So it can be done in the blood or body fluids also. And when it comes to cervical cancer, what benefits it may offer: early detection of cancer, real time monitoring of the disease. You can take serial samples and see how the disease is progressing, detection of minimal residual disease, identifying mutations so that targeted therapy can be given, and elevated levels of cell free HPV DNA levels, signal treatment failure, partial response, or resistance. Again, limitation is widespread adoption depends on the availability, cost effectivity, and accessibility. And time consuming procedure, very expensive, and highly trained staff is needed. But this is the future. As technology develops further, liquid biopsy is what is going to be the new thing. So thank you very much. This was my presentation. If there are any questions, I would
Thank
like
you,
to.
ma'am, for such an insightful lecture. Now I request the chairpersons to kindly give their valuable comments.
I think Charanjit has left no scope. Excellent. I enjoyed early morning with my cup of tea. I enjoyed this lecture also. I think Dr. Leela was posting some, comments, messaging that
Madam,
from that
some
the
questions
point
because
of care. Yeah. So I think Charanjit has highlighted it quite amply, that depending on the resources you have, like for screening, you should have the Roche Cobas, but then our
Roche
resources
Cobas
don't.
or BD oncolarity for primary screening, these are two
But
recommended.
yeah, they are recommended, but you can use hybrid capture, which is
Yes, ma'am,
quick. And
absolutely.
yes. So because for us, we have to see what is available to us and
Yes.
which has been proved. I mean, tested, time tested in the field. A
Yes.
lot of studies on that. We were part of that. So whatever is available to you. So, but you should not be. What I want to tell to the audience who are listening, you should not be, trying to do all the tests. अभी ये भी है ये भी है ये भी है, that you confuse that patient. So if you start with a simple test, your aim is that you should not be missing on to the progression of disease. Whatever test you may do, you have to call her for follow up. So yes, that will reassure her and maybe reassure us that she may not develop in the long run, persistent infection. But the availability of test based management should be done as of now for our people. And TrueNet obviously has been widely publicized and it is available, being used, and even hybrid capture has been used. So maybe the government may work on that gene expert test, for which you need cartridges and for a mass scale, uh, because we have been, having tuberculosis, national tuberculosis program. So for that also they are using it. So
True.
eventually, because the infrastructure is there, but they need only cartridges. So maybe over the years, uh, you will have those tests available. As far as E6, E7 MR, yes, they are good. Methylation markers are good, but then you should also see the cost which
Yes.
is involved in that to the patient. So don't just do it because it is available. Base your test, whatever you write, on the clinical scenario what you are facing day to day. An excellent, Charan. It was a beautiful lecture. As I had said already, I have heard it. It was lovely.
Thank you, ma'am. Thank you very much.
Leela ma'am.
Yeah, yeah, yeah. Yeah, thank you, Dr. Charanjit. You have
Thank you.
nicely taken us through the variety of HPV tests, the usefulness of each HPV test, and the use of the tests as well as the molecular markers. I just have a doubt because you said there is a false positive HPV test.
Yes, ma'am.
What
False
exactly
positive.
is the false positivity means and what is the false positive rate? Because when we see positive HPV test and when we don't see anything at colposcopy, we usually say it is a transient infection. You mean to say the transient infection you consider it as false positive
Yes,
or
ma'am.
something
Yes.
different?
Something, no, ma'am. There are, I enumerated the reasons. Okay, false positivity rate is variable, depends on how you, it's around 15 to 20%. And one of the reasons for false positivity is transient infection. So, transient infection, or as I enumerated, there is cross reactivity with the other viruses also. So with other low risk viruses also, and with other viruses also, so that could be another reason for false positivity. So around 15 to 20% false positivity is there. Also it depends on the test. Now if you look at cobas, in cobas, the we are looking for the L1 gene of the virus and then saying that the virus is present. Now this L1 gene of the virus is also shared by other low reactive low risk viruses also. So false positivity becomes a little higher. Whereas if you see BD oncolarity, it is looking, and transient infection also. If you look at BD oncolarity, it is looking for only E6, E7 of high risk viruses. So that becomes little more sensitive. So it depends on the test also that we are doing, but on an average, the false positivity is around 15 to 20%.
So what do you recommend, ma'am? You recommend a repeat test to how to come out of the false positive?
False positive, then for false, if you have a positive result, you do a colposcopy.
So
And
it's
then if
basically a clinical
colposcopy,
correlation, nothing in isolation, everything has to go out.
yes, ma'am, it has to be correlated, yes. Or
Positive.
you can, if you want, then mRNA based test can be used for triaging, or colposcopy can be done.
I think in an Indian scenario, it gets tougher the higher
Yeah,
category of tests we go for the
yeah.
patient to
It
afford.
becomes more, they become more expensive,
Yes,
yes.
yes.
No, I mean, that's why what I feel is like instead of just, I mean, of course, Nutri Madam was saying about hybrid capture tests and other things, but at least doing this partial genotyping test will give us an idea which lady needs colposcopy and which lady can be called up. Suppose if you do HPV 16, 18 positivity, mostly we triage them with colposcopy. And if we don't find anything, of course, we do have our different guidelines and other things. And probably I think in the panel discussion, they're going to discuss all those things. So that is there. That's why I'm not talking much about that. So yeah.
Ziba
Is
ma'am?
it okay, Dr. Nidhi, or there are some more questions I think Madam can answer. Then after that, we can move on to the panel discussion.
Okay,
We can have
one
a
question.
Dr. Jeeva's comment.
I think it was a very complicated topic which has been concised very nicely by Dr. Chiranjeev. Um, uh, yes, we need to go a little molecular because everything is moving towards molecular pathology now is no more HNE. We need to supplement everything with molecular. So this is so important, and screening now I think हम भी पैप स्मेयर के बाद we also recommend कि अगर कुछ भी deranged आता है, so you go for a HPV testing to help out the patient. So I think excellent talk, Dr. Chiranjeev. It was good to hear. And
Thank you, Dr. Zeba. And a lot of people are asking about cost of HPV DNA testing. Oh, so cost is actually variable. And lots of laboratories in Delhi, I was just going through, we have a Cobas 4800. We are using Cobas. Gangaram Hospital has a Cobas 4800. And then so many other, some DNA lab and Ganesh Diagnostic, there are so many private labs, and they are doing this HPV DNA testing. And for DNA testing, approximate cost, it comes like the BD oncolarity is more expensive than Cobas because it's looking for E6, E7 gene. So the cost varies from somewhere around 2,500 to 5,000. That is the cost. And mRNA based tests like Aptima are more expensive. And then methylation markers. I've been asked, are methylation tests available readily in India? And if so, okay, methylation markers are not available readily in India. One of the methylation markers, QI Assure, that can be done. Some of the laboratories, private labs, they have a tie-up and they are sending them abroad. Whereas the second methylation marker that methylation test, Gintech, which I showed in my presentation, that is not available in India. But QIA sure is available, but that is how the laboratories are having, private labs are having tie up with labs abroad, and they're getting them done for the people who want, or for the people who want to get them done.
I think, Dr. Nidhi, can I just take a break? Yeah, please carry on with the second session. There's going to be some shutdown.
Yeah,
Anna.
yeah, I think it's a nice discussion by Dr. Charanjit and all the chairpersons. Thank you, ma'am. I would like to now invite Dr. Aruna Nigam, our president and head of department of at Hamdard
Okay.
Institute,
Okay.
for
There
the
is
further
slight
proceedings.
there is a slight change in the plan because I'm getting message and Dr. Sarita has also sent me message that just reading the message that today on 7th May, kindly note 8 to 8:15 p.m. there will be electricity
blackout.
shutdown by the authorities.
Yeah. There's a
So we
blackout.
expect all lights to be switched off during this period. So we will not be taking a panel due to these reasons. So because we should be supporting the cause and we are going to take on it. So panel will be next time. We can take, I think, Dr. Sarita, do you agree with me, and Dr. Bindia also? So we can have a comments of Dr. Sarita on the same, on the HPV DNA testing. Just I want Dr. Sarita to comment on the latest results of Dr. Neerja Batla's study. Just hurriedly, if she can give us few insights on the study which Dr. Neerja Batla has just concluded.
Yeah, actually they validated the HPV test, the locally made, indigenously made HPV tests. One is Malbio, and there was another test. So and they found, so basically how the validation was done is they got the samples from IARC. So IARC had conducted a multi-centric study for on HPV testing, and so the samples of those which were positive, negative, those were brought here, and then they were tested against both against the COVAS and this and these tests, and they found good sensitivity uh, for the high risk HPV types, and there are 8 HPV types which are detected by Malbio. So, and it's going to be, however, they are, I think TrueNat is already there in the market, and TrueNat is also the one, Malbio is also the one where they made the COVID test, actually. The platform is
Yes.
the same. So
Same.
it's, yeah. Yeah, so here it's being used for HPV, and and it's already actually people, Malbio is already marketing it, and Dr. Shalini had done a study in AIMS Rishikesh earlier on this. Now, whether it is useful and how to, whether it can be for implementation on a larger scale, they will need, a massive increase in the production, as well as it also needs to be validated for self-sampling. So it's not yet for self-sampling, but for physician-collected samples.
Yeah, Sarita, I can add on to that because it is the samples have
Yes.
been brought from outside because I was part
Mm.
of that protocol ethics. So
Okay.
they have to probably test it in your own population also, and
Yeah.
to really give it a foolproof validation. Yes, although the HPV positive samples they have validated that, but I think there were around 3,000 or odd that samples they had
Yeah. Yeah.
tested. A large number of HPV positive
Yes.
samples. Yeah.
Madam, I think with the Malbio test, I think it happens in two phases. In the first phase, they need to extract the DNA from the sample. It is also cartridge based. Then after that, they load onto the cartridge, the material, and they'll get the test result. And one more thing, I'm not very sure, but I think it is quite, the machine is quite temperature sensitive. So that means, I don't know whether it will be useful in a large community
That is what
screening
I said.
programs.
They have to test it with their own first, the Indian population. They have tested those samples which were there. So probably they will do it at.
Yeah,
They,
madam. They have to
they
make
will
it, they have
start
to
at,
customize to
yeah,
the tropical
yeah,
situation. I think that is very
absolutely,
important, madam.
absolutely. Yeah.
Yes, ma'am. So I think with this, we will conclude the today's webinar. Thank you, Charanjit ma'am, for the very, very insightful talk. And I would like a heartful thanks to all the chairpersons for such a good discussion. I'm extremely sorry to all the ISCCP members that we could not have the panel discussion. We had very interesting cases, but in the interest of the country, I think we have to also sacrifice our some interests again. So thank you very much. We had a very good attendance. We had 99 participants joining in. So very, very successful first monthly webinar series. So meet you again every 7th of the month at 7 p.m. for 70 minutes. So here we are signing off from ISCCP. Thank you, everyone. Please be safe.
India, you start with the panel during the next meeting. You
Yes,
start with
ma'am.
your panel. Then
Yes,
you
ma'am.
can keep a lecture. So you can modify it a little bit so that people are not deprived of what you have prepared.
Yes, ma'am, definitely. We'll do that. We'll start with the panel and then we'll have the talk. So thank you very much. So everybody, please be safe. And I think today my thank you will be Jai Hind, Jai Bharat.
Thank you very much, Dr.
Yes.
Thank
Jai
you
Janji,
Hind.
very
for
much.
nicely conducting the
Jai
program
Hind.
and the
Thank you
easy
so
everything.
much.
Yes,
Thank you.
thank
Good
you so
night.
much, ma'am.
Thanks.
Thank
Thanks
you,
for
ma'am.
joining.
Okay, everyone.
Good night.
Good night, ma'am.